Ladies and gentlemen, I extend my warm greetings to each one of you today. My name is Sarkam Shahid Hussain, and I am delighted to be your moderator for this important webinar. As a final year MBBS student at JMTC Karachi, I am honored to be here in front of you as a representative of the medical community. I also proudly serve as a volunteer for the MHM platform. The special thing about today's webinar is that we have a surprise for you guys at the end after the query session, so stay focused. Our topic of discussion today is basics of electrocardiography, a critical aspect of medical practice. We will have the privilege of hearing from an esteemed expert, Dr. Mohammed Hashim, who is a member of the faculty in the Department of Cardiology of DUHS, Dow University of Health and Sciences. Dr. Mohammed Hashim expertise and insights will undoubtedly enrich our understanding of this vital subject. But before we delve into the details of our topic, I would like to take a moment to shed light on the remarkable work being done by two organizations that are making a significant impact on our society, the MHM platform and Project IMG. The MHM platform, founded in 2018, has a noble mission of assisting students in Pakistan. This platform stands as the first and only one of its kind in our country, providing free guidance to MCAT and medical university students on annual basis. To date, the MHM platform has successfully guided over 300,000 students across Pakistan. One noteworthy initiative of the MHM platform over the past year has been the provision of free career counseling sessions to students in various educational institutions, including schools, colleges, and coaching centers. Their dedicated team interacts with the students in ninth, 10th grade, in first year and second year as well, guiding them towards different fields based on their interest. Their aim is to help the students comprehend the diverse array of available options and empower them to make informed decisions about their future. Now, let me introduce you to the Project IMG, a limited liability company based in the United States. This organization was formed with the purpose of providing US medical education program and opportunities to international medical students and graduates. Their efforts have resulted in the development of a private membership network that connects, supports, and resources over 35,000 medical students and graduates from 185 plus medical schools in 90 plus countries around the world. Project IMG offers free access to a wide range of medical education programs, including online courses, US MLE exam preparation, didactic lectures, clinical rotations, medical research opportunities, mentorship programs, employment assistance, and many more. Today, we are truly honored to have Dr. Mohammed Hashim as our distinguished guest. Dr. Hashim, a member of the faculty of the Cardiology Department of Dow University Health and Sciences, has graciously devoted his time to share his expertise with us. We extend our heartfelt thanks to him for his valuable presence. As we embark on this webinar, let us open our minds to the wealth of knowledge that awaits us. Dr. Hashim will provide us with insights into the intricacies of the basics of electrocardiography. I invite you all to actively participate, ask questions in the comment box, and engage in the enlightening session. Once again, thank you for joining us today, and let us begin this journey of knowledge and discovery.
Thank you very much, Arkham, for your introduction, and I'm thankful for Hamza to have me or for this academic activity. So let's start our session with the name of Almighty Allah. Bismillahir Rahmanir Rahim. As Arkham introduced me very nicely, so I work here in Dow Institute of Cardiology as an assistant professor of cardiology and as an interventional cardiologist. So today's session will be on very basics of ECG. So as we have different groups of participants that we do have practicing practitioner and we do have medical student, nursing staff and technicians. So we will be touching very basics of ECG. So keeping in mind our audience. So, what is an ECG? ECG is the device that detect or that records electrical activity of the heart. We know that heart has two functions, that is electrical activity as well as mechanical activity. The electrical activity of the heart is recorded by ECG. Now, any one of you can guess what is this? So I give another clue. ये क्या है? This is a cricket ground, right? And in black dots you can see there are different cameras in cricket ground. So if we don't have such cameras, so बहुत सारी the foul play would be missed, or you won't be able to decide uh, honestly. So that's why in ECG we do have different leads. We do have 12 different leads to monitor the electrical activity of the heart from different angles, so that any important activity or damage should not be missed. That's why. Now look at it. Agar camera, if the camera is seeing it or looking it from the behind, you won't be able to decide ke, is it out or not out. But look at it. This can clearly says that it is clearly out. Now that is the importance of. That's why we do have 12 different leads, six precordial leads and six limb leads, not to miss any important activity. Now, why do we need ECG? What are the function of ECG? ECG monitors patient heart rate and rhythm. ECG will weigh different diseases of the heart as well as different systemic diseases, which how does that affect on the heart. Now, it also detects presence of electrolyte disturbances and other diseases. Now, these are the different. Why do we need ECG? Look at it. If we don't have that 12 leads, we will miss the foul play. Again, foul if you people are interested in cricket, you must realize that they are tempering the ball. So now, you must know this gentleman, Afridi, who is once involved in ball tampering. Now, before embarking on ECG, you must know the importance or how does the ECG paper look like, on which the electrical activity of the heart gets recorded. If you see the ECG paper, you will see there are two types of small boxes, two types of boxes, one big box, another small box. Every big box contains five small boxes on the horizontal surface and five vertical boxes on the vertical surface. Now, the big box contains what the ECG paper's time duration gets recorded, while on vertical axis the electrical activity or the voltage gets recorded. Now, every one small box uh, has a time duration of 0.04 seconds, and every big box does have zero point 0.2 seconds, while on vertical axis one big box is equal to 1.2 millivoltage, sorry, half millivolt. Now this is the small, this is the big box, and one big box having five small boxes on the horizontal and five on vertical. Now, this is how one standard ECG looks like. Now, you can see on the left side of the screen that there are 12 limb leads, six limb leads, lead 1, lead 2, lead 3, AVR, AVL, and AVF, and then six precordial leads from V1 to V6. Right. This is the and the in the end you must have one long strip that is called rhythm strip. So one ECG must have the 12 lead. Complete ECG should have 12 leads and then a rhythm strip as well to comment on that. Otherwise, you will miss important findings. If you don't have complete ECG, you will miss important findings. So whenever you commenting on ECG, you must see that all the 12 leads are present or not. Number two, you must have the rhythm strip in the end. Now, is this ECG is complete or not? No, this ECG is not complete. Why? Let me tell you another slide. I think my presentation is not working. Now, why that ECG is not complete? Because it doesn't have the standardization in the end. The normal standardization is the speed of the paper of ECG should be 25 per second, and the voltage should be 10 is equal to 1 millivolt. It means that the 1 second of electrical activity should be measured in 25 of the paper, 25 paper of the ECG strip. And the electrical when 1 of 1 millivolt of electrical activity produced by the heart, that should be on 10 of ECG paper. Without these calibration, because your heart rate, your hypertrophy, your ST elevation, everything depends on that speed or that calibration. If that calibration is not mentioned, you won't be able to comment on any of these things. So complete ECG should have 12 leads. Along with that, there should be a rhythm strip. Along with the rhythm strip, there should be calibration, should be mentioned in the end of the paper or in the top of the ECG paper. And the calibration, normal calibration is 25 per second for the speed, and for the voltage is 10 is equal to 1 millivolt. Now, before going into the deep, let me tell you that we should be very familiar with the position of the heart. The heart is not present on the left side, but it is presented retrosternally, and it is directed towards left and down left foot of the body. Now, before going for detail of ECG, let me tell you there are different waves, segments, and intervals on ECG. Now, what is wave? Any positive or negative deflection on ECG paper is called wave. We do have multiple waves. Positive means the wave which is formed above the horizontal line is positive. The wave which is present below the horizontal line is negative wave. So we do have two negative wave, while five or six four positive waves. Now we do have P, Q, R, S, T, and sometimes U waves. Now, along with that, there are segments and intervals. Now, what is segment? Segments is the horizontal line from the end of one wave till the beginning of the another wave. We do have a period or time which is called segment. And what is interval? Interval is combination of different segments. At least a segment should interval should have one segment and one wave, but an interval can have multiple segments and multiple waves. So we do have PR interval, which contains one P wave along with PR segment. We do have PR segment. We do have ST segment. The importance of all these segments and interval will be coming in upcoming slides. So you must know that we do have different waves, segments, and interval on ECG. Now, how does impulse conduction starts and how does it appears? Now, the sinoatrial activity produces the electrical activity. Then it goes to it depolarizes all the atria. When it depolarizes all the atria, the wave generates in on ECG paper is P wave, and then it goes to AV node. In AV node, there is a uh, brief stop in electrical activity, and that comes on paper with the PR segment or PR segment. And then after that, it goes to right the bundle of his, and then along with that it goes to right bundle and left bundle, and then it depolarizes all ventricle. When it depolarizes the all ventricle, the waves that produces on ECG paper is QRS complex, and then the waves all get repolarizes, and repolarizes we do have T waves. Now, PQRS, these are the waves that we do have on ECG. P wave is for atrial depolarization, and P wave represents the atria. P wave represents the atria, and QRS complexes repolarizes, and QRS complex with the when the ventricle gets repolarized. Now, before going into detail, you must know where the electrodes gets attached on the surface of the body when we going to have these ECG. Now, we do have six precordial leads. That the precordial leads should be on starting from the fourth intercostal space, from the from the right side, then second on the left side, and then the rest of the uh, electrodes attached on fifth intercostal space. And then we do have three limb leads: limb lead 1, limb lead 2, limb lead 3. Limb lead 1 is in between the two arms, limb lead 2 is between the right arm and the left leg, and limb lead 3 is between the left leg and the left arm. ECG. And what we do need to know now, we should know the rhythm by ECG. We should know how to calculate the rate based on ECG, heart rate. We should know the axis of the heart. We should know how does ischemia represents on ECG, and then chamber enlargement, either atria or left atria, or ventricles enlargement, either left or right ventricle or atria gets enlarged. How does it appears on ECG? And then in the end, we should know the blocks. If we if you get be with me for the next 10 or 15 or 20 minutes, one by one we will go through these topics. Now, rhythm. What is rhythm? What is sinus rhythm? When we call it sinus rhythm, whenever every QRS complexes comes after P waves, every single P wave, after P wave there is a QRS complexes which is represents, and this ECG is called sinus. Any deviation from this rhythm is non-sinus. So every QRS, look at the ECG. In this ECG, you will have every QRS complexes comes after P wave. Every QRS, there is no misbeat, there is no any electrical or atrial activity without ventricle activity. Every P waves and then QRS complexes. Now, these are the most common arrhythmias which we do have. That is atrial fibrillation, atrial flutter, and multifocal tachycardia. That is, in atrial fibrillation, we do have uh, irregular rhythm. There is absence of P waves, and the QRS complexes vary. Right. This is the atrial fibrillation, which is the most common arrhythmia. And we do have, there's a lots of arrhythmias. We won't go into detail, but you must know how does sinus rhythm looks like. Sinus rhythm, every P wave followed by QRS complexes, right? And then any deviation from this rhythm is non-sinus rhythm or arrhythmia. And the most common arrhythmia is atrial fibrillation. Atrial fibrillation, absence of P wave with QRS variation. Now, how do we calculate the heart rate in a patient on ECG paper? We do have different methods: small square method, large square method, and fast clinical method. Let's see how do we have these. In large square method, if if there is a between the two QRS complexes, we get two consecutive QRS complexes. If the in between the two consecutive QRS complexes, the gap is 1, then the heart rate would be 300. If the gap is 2, big square, the heart rate would be 150. If the gap is 3, then the heart rate would be 100, and then 475, 560, and so on. How do we calculate on small square method? We do calculate the small boxes in between the two consecutive R waves, and then gets divided by 1500. The number we get is the heart rate. So these are the different methods by which we can calculate, and we do calculate the with this large square method. In large square method, we do, we take it two consecutive R waves and then calculate the big boxes. Calculate the big boxes. How much big boxes do we do have? Divided by 300, we get the heart rate. Now, this is all for sinus rhythm. For non-sinus rhythm, these all three methods won't apply. Then how will we do calculate the heart rate? We do have 6-second strip. In a 6-second strip, we have 30 big boxes. जैसे हमने कैलकुलेट किया था ना वहां पे, one big box is equal to 0.2 second. So we take 30 big box. In 30 big box is equal to 6 second. So in that 30 big box, we calculate the QRS complexes. How much QRS complexes we do have in 30 big box, and then multiply by 10. The number we get after that multiplication is the heart rate. One big box is equal to 0.2 second. 30 big box is equal to 6 second. If we multiply 6 by 10, the heart rate, that would be 60 second, is equal to 1 minute. That's why we calculate the QRS complexes in that 30 second, in that 30 boxes, and then multiply with the 10, we get the heart rate. This is for non-sinus rhythm. And for sinus rhythm is small square method, large square method, and fast clinical method. Now, axis determination. Axis, what is the neck axis? What is the net current flow towards the heart? For axis determination, you must look only these two leads, lead 1 and lead 2. If both the leads are positive, then there would be a normal axis. If the lead 1 is negative and lead 2 is positive, then it would be right axis deviation. If the lead 1 is positive and lead 2 is negative, it would be the left axis deviation. If both the QRS complexes are in both lead V1 and lead 2 is negative, then it would be extreme left axis deviation, or extreme axis, northwest axis. Now, what is the axis in this ECG? Look at the ECG. In lead 1, we do have positive QRS complexes, while in lead 2 we do have predominantly negative QRS complexes. So lead 1 is positive and lead 2 is negative. It is
It
left.
is left.
Now, what is the axis in this ECG? Look at the ECG. We do have positive in lead 1 and positive in lead 2. So both the QRS complexes are positive in lead 1 and lead 2. The axis is normal axis. Now look at this ECG. In this ECG, we have in lead V1, in lead 1, the QRS complexes is predominantly negative, and the QRS complexes in lead 2 is positive. Here it is negative, here it is positive. Lead V1 is negative and lead 2 is positive. So right axis deviation. And now look at this ECG. In both the QRS complexes in lead 1 and lead 2, both of them are in negative. So it is extreme axis deviation. Now ischemia. For ischemia, there are different ECG changes that you must know. That is ST elevation, ST depression, hyperacute T wave inversion, pathological Q wave, and left bundle branch block. These all are the ECG changes that can be observed, and usually it is isoelectric line from the end of the one wave till the beginning of the another wave. Now here you can see that it is from the end of QRS complexes to the start of the P wave. The segment is called ST segment. If it gets elevated, it's elevation, where the QRS complexes ends and the ST segment starts. The from lead V1 to lead V6, there are ST elevation. So this is how ECG on ECG paper ST elevation looks like. Now this is the evolution of MI. Look at here. So on ECG, there are diffuse ST elevation in lead 1, AVL, and from V2 to V6. And there are ST depressions in lead 3, lead AVF, and AVR. So ST elevation in lead, how we will interpret this ECG? We will interpret this ECG as extensive anterior wall MI, involving both the anterior wall and the lateral wall. Now, this ECG is such an informative piece of paper, which doesn't only tells you that which segment of the heart is involved, but it also tells you which artery is involved. Now, if we do have ST elevation, it would be inferior wall MI, and in inferior wall MI, most of the time, the culprit is right coronary artery. For anterior wall MI, there would be ST elevation from V1 to V6, and for lateral MI, we do have ST elevation in lead 1 and AVL. So it doesn't only tell you that the patient is having MI, but it also tells you which wall of the heart is involved, number one, and which artery is the culprit artery. So in ST depressions, we do have different types of ST depression. horizontal ST depressions, vertical ST depressions, and downsloping and upsloping. Downsloping and horizontal ST depressions are very sensitive for ischemia, while upsloping ST depressions are not that much. So this is how ST depression looks like on ECG paper. There is a diffuse ST depressions in this rhythm strip, horizontal. Now, how does this ECG tells? There are ST depressions in lead 2, 3, and then in precordial lead as well, along with sinus tachycardia. Now, this is the LBB pattern. This is one of the presentation of acute MI, LBB, right? So history and clinical examination is very important while having ECG interpretation of ECG. Now Q waves, what is Q? What does Q wave shows? Q waves is the first negative. What is Q wave? Q wave is the first negative wave after P wave. So when we call it significant when the Q wave is present in two consecutive leads. Number one, number two, if it is more than one third of the R waves. Number two, it should have a length of at least three small squares. Then it is significant. Otherwise, it is not. So what does it tell? It tells previous old infarct. Previously, patient is having infarct or the territory is infarcted. Now, chamber enlargement, we do have four chambers, two atria chamber and two ventricle, right? So, as in initially, I told you that P wave represents atria. So we do have right atria and left atria. Now, for left atrial enlargement, for atrial enlargement, we only see P waves in two leads, that is lead 2 and lead V1. Normally, in lead V1, we do have bifid P waves. Normally, in lead V1, we do have bifid P wave, and that is identical. That the initial half and the later half is same. Whenever the initial half represents the right atrium and the later half represents the left atrium. Whatever the case may be, if the left atrium enlargement in lead V1, there would be a broad later half, second half of P wave. While if the right atrial enlargement is there, then you will have long first portion of the V1. I will show you on ECG, then you will realize it. While in lead 2, what we do have, if there is right atrial enlargement, right atrial enlargement, the duration of the P wave would be the amplitude of the P wave would be high. That would be more than three small square. There is duration would be, this is left atrial enlargement. You can easily see that the duration of the P wave is more than three small square. Number one, and you can appreciate here that the later of the P wave, the later, this is the initial half of the P wave in lead V1, and this is the later half. You can see that the later half is larger than the initial half. So this determines that in this patient we have left atrial enlargement. While in right atrial enlargement, as I told you, that the P wave height would be increased. If it is more than three small square in height, and the initial of the half of the P wave in lead V1 is increased, so it is called right atrial enlargement. You can see in this ECG that in lead 2, for light atrial enlargement, what we would do have heighted P wave, while the initial part of the P wave would be enlarged. While in left atrial enlargement, the duration would be increased, and the later half of the P wave in lead 1 would be enlarged. For left ventricle enlargement, what we do, we see only QRS complexes. QRS complexes may, we do have different criteria for left ventricle enlargement and for right ventricular enlargement. Let's see, we do, and these different Sokolov criteria, what we do see, हम क्या देखते हैं उसमें, we do have QRS complexes in V5 or V6, whatever is uh, prolonged or larger, and then we do have S wave in V1 and V2. We do combine these two. Again, if the sum of that is more than 35, we say it is left ventricular enlargement. Sum of R wave in V5 or V6 and S wave in V1 or V2. If it is more than 35 small squares, it is called left ventricular enlargement. Here you can see that there is a large R wave. 1, 2, 3, 4, 5, 6. 6 is equal to 30 small boxes. And then we do have 1, 2, 3. 3 large boxes here. 3 large boxes here, 6 large boxes here. So 3 and 6 is equal to, at least the small squares are more than 35. So this is left ventricular enlargement. Now for RVH, if the R wave is more than S wave in lead V1, or if the R wave is less than V6, if the R wave is less than S wave in V6, it is called right ventricular hypertrophy. Here you can see the R wave is more prominent than the S wave. So this is right ventricular hypertrophy. And this is what about hypertrophy. And now heart blocks. We do have different heart blocks: first degree heart block, second degree heart block, and third degree heart block. Let's see one by one. In first degree heart block, every P wave would be conducted to R wave, or there you will see QRS complexes after every P wave. How much prolonged gap, and then QRS complexes. Normally it should be within one large box. If it is more than one large box, the gap between P wave and the QRS complexes, it is called first degree outlet. But there is no misbeat. You can see that the regular rhythm, but the PR interval is prolonged. This is called first degree AV block. What in second degree AV block? In second degree AV block, we do have two types: Mobitz 1 and Mobitz 2. In Mobitz 1, there would be progressive prolongation of the PR interval, and then you will have misbeat. You can see on the first, it is Mobitz 1. There is progressive prolongation of the PR interval, and then there is a misbeat, right? While in Mobitz type 2, the PR interval is prolonged and fixed. The PR interval is prolonged and fixed, and you may have sudden absence of QRS complexes after one P wave, right? This is called Mobitz type 2. What about complete heart block or third degree heart block? In third degree heart block, you will have this three characteristic findings. The R to R interval would be same, the P to P interval would be same, and there would be variation in PR interval. Look at here now. The R to R interval is same, and the P to P interval is same everywhere. But there is a variation in PR interval. Look at here, the PR interval. यहाँ पे देखें. Look at here, PR interval कितना है, इधर कितना है, इधर कितना है. The PR interval is varying, but the R to R interval is same, P to P interval is same, and you will have another which is not the characteristic finding, but you must have in every patient with complete heart block that you will have more P wave than QRX complexes in complete heart block. Now, any one of you can comment on this ECG. Now, before commenting on ECG, is this a complete ECG or not? This is not a complete ECG. Why? Because there isn't any rhythm strip. Oh, I missed there is a lead 1, lead 2, lead 3. Along with that, we do have rhythm strip, right? And there is a calibration mentioned. Normally, if someone sees this ECG without calibration, he will report that this patient is having hypertrophy. But actually, it is not. Why? Because the calibration is 20 mm per milliwatt. This is not a normal calibration. The calibration has been doubled to 20 mm. Normal calibration is 25 mm per second, and the calibration should be 10 mm per millivolt, right? So इस ECG में that's why you having long T or hyperacute T waves like waves, and you are having long QRS complexes. That's why you must have this normal calibration before commenting on ECG. Now, what does this ECG shows? Is this a complete ECG or not? No, this is not a complete ECG. This is only showing rhythm strip, right? And precordial, only precordial leads is there. And grossly, if someone comment on this ECG without seeing the calibration, they will they will say that the patient is having bradycardia, but actually he is not, because the calibration is 50 per second, which is the calibration is being doubled. That's why you should not comment on ECG before seeing the calibration. Is very important. But about this ECG, here the calibration got smaller, so you may have small QRS complexes, and you will be having very difficulty in identifying the P wave. These all ECG is of a patient with different calibration, of the same patient with different calibration, and you can see that all the things has been how things or waves gets changed with change in calibration. Now, thank you very much. And if you have any question, you can write on your box so I can comment. I will try to answer your questions.
All right, so thank you, Dr. Hashim, for such an insightful thoughts. Guys, please ask your questions, write your questions in the comment box so that we can answer.
Oh, can we get a PDF for this?
Don't worry about that. This session will be uploaded on YouTube, and we will see if we send a PDF to you.
Oh, okay, okay, cool. Thank you, sir. Thank you.
Please write your questions in the comment box so that I can deliver it to Dr. Hashim and he will respond to that. Dr. Hashim, explain ST segment elevation MI.
Okay. ST elevation amount. ST, look at, you will have ST segments. We do have different, I told you that we have different waves and segments on ECG. So ST segment is a part of the QRS complexes when there is no electrical activity. It starts from the end of the QRS complexes till the beginning of T waves. Normally, this is a horizontal line, and it is called isoelectric horizontal line. What happens in myocardial ischemia? The electrical activity gets disturbed to the specific part of the heart, and then the electrical activity gets disturbed. So here, so what happens here, the ST gets elevated in that respective ECG leads, which represents that specific part of the heart. So this is how, if the patient is having anterior wall MI, the leads which represents the anterior wall, the ST gets elevated there. Normally, this segment should be horizontal to the PR segment. If the PR segment is down and the ST segment is get elevated in the two or more respective leads, so उसमें क्या होगा then ST elevations that represent the ST elevations. This is how ST elevations look like on ECG paper. Normally, A is normal. It should be in a line with PR interval or PR segments. If the PR segments gets down and the ST segments gets elevated, it is called ST segment elevation. And normally, it should be, when we label it as a ST elevation MI, it should be in two consecutive leads, means in two leads which represents the same territory. If we get ST elevation in two perspective leads, consecutive leads, then we call it ST elevation MI. Otherwise, it is not. So this is the ST elevations in lead 1, AVL, and V 2 to V6. There are ST clear cut ST elevation. In true ST elevation MI, you will have reciprocal changes in other leads. So there are ST depressions in both.
Yes, sir. The next question is, what's the difference between Mobitz Type 1 and Mobitz Type 2?
In Mobitz type 1, as I said earlier, that you won't have any misbeat. You won't have any misbeat. What you have, there would be prolongation of the PR interval. Normally, the PR interval should be within one large box. One large box means zero point 0.2 second. If that duration gets increased more than one large box, or more than five small boxes, or more than zero point 0.2 second, it is called first degree AV block, and you won't have any misbeat. Every P wave followed by QRS complexes. Every P wave followed by QRS complexes. While in Mobitz type 2, what happens? While in Mobitz type 2, what happens in Mobitz type 2? क्या होगा इसमें? The PR, there would be prolongation of the PR. Along with that, you will have misbeat. You will have electrical activity that is not passed to some electrical atrial activity which is not passed to ventricle. So you will have misbeat in Mobitz type 2, but not in Mobitz type 1.
Okay, so the next question is, please repeat the axis deviation.
Yes, for axis deviation, as I said, we do have we see two leads, that is lead one and lead two. Previously, lead one or lead two or AVF देखा जाता था, but now only we see lead one and lead two. We call it two thumb method. उसमें होगा ये कि if both the just represents with two thumb method, lead one is your left thumb and lead two is your right thumb. If both the leads are positive in a positive direction, QRS complexes, we are talking about only QRS complexes. Lead one represents lead two represents your right thumb and lead one represents your left thumb. If both the QRS complexes in a positive direction, it's called normal axis. If lead one is negative and lead two is positive, it is called left axis deviation. If the lead 2 is negative and lead 1 is positive, it is left axis deviation. If both the thumbs are, or both the QR axis complexes in both lead 1 and lead 2 is negative, it is extreme axis or northwest axis deviation, which I have shown on my different ECG paper.
All right. Sir, how can we calculate atrial rate and ventricular rate for a non-sinus rhythm?
Yes, for atrial rate, you will calculate, you will see the calculation method is the same. That is, you will see P to P interval. And P to P interval, what you calculate the number of small boxes in the interval and the number of large. For atrial, sorry, for atrial, for ventricular rate, what you need to do is you need to calculate both the number of large boxes or the small boxes in between the two R waves, and then divided by either 1500 or 300. The number that is you get is ventricular rate. आपने एट्रियल रेट अलग कैलकुलेट करना है, वेंट्रिकुलर रेट अलग कैलकुलेट करना है. एट्रियल रेट के लिए व्हाट यू नीड टू डू इज एट्रियल रेट के लिए व्हाट यू नीड टू डू इज आपने दो पी टू पी का गैप देखना है और वही मेथड अप्लाई करना है जो हार्ट रेट के लिए करते हैं. और वेंट्रिकुलर रेट के लिए आपने आर टू आर का गैप लेके उसको कैलकुलेट करना है. 1500 और 300 से डिवाइड करके आप वेंट्रिकुलर रेट कैलकुलेट कर सकते हैं. For this is for the blocks in which the atrial rate is different, and the usually we do calculate on complete heart block. Complete heart block में atrial rate अलग देखते हैं, ventricular rate अलग देखते हैं, R to R interval देखते हैं, और पहले हमने बताया.
All right. Thank you, Dr. Hashim, for the explanation. This is a wonderful session. Now, I'm going to reveal today's surprise, as we are honored to have with us the founder of the MHM platform, MuhammadHamza Muhammad. With us, his insights and ideas are all set to illuminate our gathering. So, please, Hamza, over to you.
Hello, Assalamu alaikum, everyone. Am I audible to you?
Yes, please.
Yes, you are.
Okay, great. Thank you so much for your kind words, welcome. It's been an honor to share screen with you and Dr. Hashim. I have listened the whole webinar. First of all, sorry to all the participants because many participants were waiting in the list, but due to overloading of the participants, overcrowding of the participants, many people were unable to join. So we are sorry for that. I think it's a privilege to talk something motivational right now. I just want to share a short story and then we will end the webinar. It's a it's a it's a story that played a very significant role in my life as well. There was a man who was walking along the seaside, and when he was walking along the seaside, he saw that there are several fishes that are lying outside the sea. They are outside the water. As we all know, fish without water can't survive; they would die. So that person started throwing the fishes one by one into the water just to save their life. So there was another man passing by nearby, and he asked that man, "What are you doing, man?" So he replied that, "Can't you see there are thousands of fishes who are here and who are out of the water? I am just trying to save them." So "Can't." That person said, "There are many fishes. There is an overwhelming number. Thousands of fishes are outside the water. How can you save all of them?" So then that man replied, and that the man replied with a golden word. He said, "If I didn't try, none of them would might survive." So what I'm trying to say and what my message of today's is, try to focus on things which we can change, which we can influence. Instead of criticizing anyone else, instead of giving excuse to anyone, try to focus on things which we can change. It's like a game. It's like a game. We play our strategies. We do our work. We play our part. We don't focus on what opponent might do or what external events can happen. So try to focus on things which we can change, so that it will create a positive impact on our life and obviously in our society as well. Lastly, I just want to thank Dr. Hashim. He's a very charming person and he's full of energy. I wish you all audience should meet him personally as well. So you will witness what I am trying to say. So thank you, Dr. Hashim. Thank you, welcome. Lots of love to everyone. I just want to mention the countries who have joined today: Pakistan, India, USA, Azerbaijan, Russia, UAE. Lots of love to everyone. In Urdu, we call love as pyar. So lots of pyar to everyone. And thank you. Thank you so much. Over to you, Arqam.
All right, G. So please feel free to email us if you need more help. Also, there will be more webinars in the future where you can ask your questions if we don't get to them this time. Thank you everyone for your time and attention. See you in the next session.